really a great honor for me to be here and talk about things that I'm really very passionate about, and that is on the one hand research in sleep, and then on the other hand my passion to care for people with epilepsy and to do this both combined. And I really think that it's a topic which is relevant. Sleep is relevant for all of us, and probably it was on purpose that I was given the last talk so late at night. Okay, and with that, I will start the presentation. I have no disclosures relevant to this presentation. And so basically what I would like to discuss is very simple questions. The first is the concept of what is good sleep. And it's not as easy as we think. And then the next one is which came first, the chicken or the egg? Or in other words, to talk about the bidirectional relationships between sleep and epilepsy, because it's not only that sleep affects epilepsy, but also epilepsy affects sleep. And then the question is, what is first? And then the last point I want to touch and discuss is now, how can we treat disturbed sleep in general, and then highlight how we can treat it particularly in people with epilepsy and provide some considerations. So now let's start. What is good sleep? And I'm sure if I ask different people in the audience, we will get different answers to this question. So in general, everybody sleeps, and that's a picture actually of one of my cats. That's Yuri. And so I always have somebody to observe sleeping near me, and as you can see, sleep is a universal phenomenon. So every human and every animal experiences sleep. And so therefore it must be something important, right? Because otherwise, why do we need to do it? And then evidently, and I think that is very, very crucial, that sleep varies across the lifespan, right? And I just illustrate here how it changes, right? If we look at a newborn, they are sleeping nearly most of the day. And then that changes and becomes less. And then if we look at middle age, so 18 to 64, so then it's usually the recommendation 7 to 9 hours, and then it gets a little bit less after age of 65. So we really see it's a dynamic process, and we have much more when we are very young. And so that also points for the role that we really need that sleep for maturation and becoming what we are. But there are much more answers, and at the end of the day, it's not so clear as we think. But there are some concepts. So why is sleep important? So evidently sleep is important for our physiological health, right? And that we very well know. If we don't sleep well, we are not doing well, we are not functioning cognitively well the next day. So it's important for our cognitive function in everyday's life. And last but not least, also waste management. So now these are all concepts, and I hope I could convince everybody that sleep is not something we should spare and reduce to have more awake time, but it's really something crucial and something very important. Now we can see at it of a different angle. So there are two components to the answer, what does good sleep mean? So the one is about quantity, right? And then if we look what the NIH recommends, so they recommend for adults around 7 to 8 hours of sleep per night. But quantity is not all in the equation, it's also quality. And this quality, evidently, this is what we feel, what we perceive, and also what we can objectively measure. So basically, it's two important things. The one is the quantity, and the other is the quality. And I would think that the second one is probably even more important if we consider it. So now comes a question I want to discuss, and this is, what do we physicians do to study sleep? And so basically there are different measures, and this is something which is always the most important, is to talk to the patient and really get a very good history on sleep. So I think that's really key in the first assessment. Then evidently we have many questionnaires that we can fill in and then also draw conclusions about the sleep quality, insomnia, risk of obstructive sleep apnea, other disorders. And then finally, we also have a means to objectify good sleep, and this is via sleep studies, also called polysomnography. And now the question is, what is happening during a polysomnography, and that is illustrated here. So basically, we all know what is the EEG, right? But then in addition, when we study sleep, we don't only have the electroencephalogram, but we have in addition different measures to assess muscle activity, eye movements, but then also cardiorespiratory monitoring. And so basically a polysomnography is like the EEG, but then with many more multimodal measures. And usually typical sleep study in the lab environment is exactly for 8 hours, during which then different parameters of sleep are assessed and objectified. Okay, so now, which comes first, the chicken or the egg? And I'm sorry to disappoint, but I can't give the final answer. And I think the final answer is probably a mixture between both. So we really have this strong bidirectional relationships between the two. And so that is illustrated here. So on the one hand, and I want to start a discussion here, how does sleep negatively influence epilepsy? And that is something that probably many of you made the personal experience, that if one has a night out, not a lot of sleep, that might indeed trigger seizure risk. But I will go in more details here and talking generally, how frequent are sleep comorbidities in epilepsy? And actually it is something we all know, it's frequent in the general population, right? Sleep problems are one of the most common problems in general. However, if we look in people with epilepsy, then affects up to 50% of people with epilepsy. So that means if we look here in the audience, it must be many people who are affected by disturbed sleep. Another component is that there is a certain subtype of epilepsies that are strongly associated with sleep. So that's so-called sleep-related epilepsies. And so this is also a very important group to characterize. But in general, sleep is really an immense role if we see in people with epilepsy. And now, what are the common sleep disorders that we see in epilepsy? So very frequent, and I will explain exactly what every of these diseases means, is insomnia. We have then the group of sleep-related breathing disorders, and there I want to talk a little bit about obstructive sleep apnea. We have parasomnia, such as sleepwalking, confusional arousals, and then we have sleep-related movement disorders, such as restless leg syndrome. But what I want to touch particularly base today is the two most common ones, which is insomnia and sleep-related breathing disorders. Okay, this is just how frequent are these phenomena, and these are different studies, and they really highlight that they affect many people, ranging from 30% to around 60% of all people with epilepsy. So it's something frequent. Now, how is insomnia defined? It is defined as the difficulty to initiate or maintain sleep, plus it has a negative impact on daytime functioning, and there are common screening tools one can use. But what is very important for the diagnosis of insomnia, it's really a chronic process as going along with difficulty initiating, maintaining sleep, plus that negative impact on daytime functioning. And basically, how do we define that? And this is based on the DSM-5 criteria here. There is a dissatisfaction with sleep quantity, quality. It occurs even with chances to sleep. It is presence, and I said chronic, so that means for more or at least 3 nights a week for at least 3 months. And it's not in the context of other problems which can lead to poor sleep. The other thing which is very frequently is so-called sleep apnea, and this is characterized by interrupted breathing during sleep. And that very often is due to the collapse of upper airway, absence of inspiratory effort, or both. And there are evidently certain risk factors such as older age, even being male, weight gain, or sleep interaction related to nocturnal seizures. And there are certain screening questionnaires what a physician, for example, in the epilepsy clinic can apply to screen for obstructive sleep apnea, and this is one of these questionnaires. And when a certain number of symptoms are present, then there is a high risk, and then further investigation should be prompted. Now, what we understand very well is this poor sleep quality is associated with poor quality of life and also increased presence of mood disorders. However, it's also like poor sleep quality increases seizure, and therefore it's really important to look for a good night's sleep. Now, let's take the other round. So we start, how does epilepsy aggravate sleep? And basically, we know that if we look at the presence of seizures, and that's from an excellent meta-analysis from colleagues, they found that in general, if you look compared throughout the 24-hour cycle, most of the seizures occur during sleep, and only very, very few occur during a specific sleep, which is the rapid eye movement sleep. That is the sleep where we usually dream. And there is also something we discussed earlier this morning in a symposium, that these seizures occur at different times, and very often they are related to sleep. There are circadian patterns, but also other patterns, and very often it's a very individual thing. So what is true for me is maybe not true for somebody else. So there are specific patterns that we can see. So seizures is not something that comes out of the blue, but there is a certain pattern if one studies for a long time period the phenomenon. And even it can occur at circannual rhythms. And evidently that is something which would be very interesting, because it opens new avenues that one could specifically tailor anti-seizure medication, for example, according to the seizure forecasting. So this is, I think, really something that could be a next breakthrough. Also, what is important is, it's very clear to everybody, if you have a focal to bilateral tonic-clonic seizure, a big seizure, then it's very clear for all of us that, yes, if that happens out of sleep, you are awake afterwards. However, and that is research done in the lab by one of my previous postdocs, is that even if you have very subtle seizures, right, you don't see really much if you look at the video during the seizure, but indeed, nevertheless, even these small seizures can result in awakenings or mini-awake reactions. And that evidently disturbs good sleep. And then what we find, it's not only seizure, but it can also be activity between the seizures, the so-called epileptic spikes that can disturb sleep. And then finally, we could talk for hours on that, anti-seizure medication and influences on sleep. This is evidently something I listed here, incidence of somnolence, daytime sleepiness, and then evidently also increased risk of insomnia. So epilepsy, it's very, very complex if we want to think, why do we have the sleep disorders, and what are contributors, what are modulators, and therefore it's really very important to very carefully investigate to find out. Now, how do we treat disturbed sleep in general? And so the good thing with sleep is there's really a lot we can do for good sleep. And so basically there are a lot of general measures that is true for everybody if we have poor sleep, what we can do. The first thing is not usually to take sleeping pills. The first thing is really to do modifications on, for example, improve the bed environment, limit, for example, caffeine consumption, have really a regular sleep-wake schedule, do regular exercise, really use the bed for sleeping and not for watching TV, find a comfortable bed environment. And that's particularly true for teenagers. Very often do not have your cell phones near the bedside, and create a wind down routine. So these are the sleep hygiene rules that we can really use also to improve sleep, and really go through them first before really thinking otherwise of medication. Then another thing for insomnia, in particularly, it was really shown that it's particularly non-pharmacological treatment consisting of cognitive behavioral therapy that are really key and on the long term much more effective than traditional sleeping pills, but then evidently it always depends what is the reason for the insomnia. There's also pharmacological treatments of different kinds available. Now, obstructive sleep apnea, we talked about the cessation of breathing during sleep. So there we have very effective treatment consisting of this continuous positive airway pressure, which results to open up the airways and keep it really open during the night. Now I want to just make some special considerations for people with epilepsy, and as I already mentioned before, it's really disturbed sleep and daytime somnolence can be multifactorial. It can be due to the disease itself, seizure control, comorbidities. We know that people with epilepsy have also higher prevalences of anxiety disorder, depression. Evidently, that doesn't make you sleep well. Medication, this is really something to very individually discuss with your epileptologist. But what we know is improved sleep decreases seizures. So it's really important, particularly in epilepsy, to try to have a good night's sleep. And then also there is some work out that sleep apnea treatment decreases seizures. So if you use it regularly, it can result in higher seizure-free rate and reduced epileptic activity in sleep. And then evidently very important is to keep a regular sleep-wake cycle and have sufficient time planned for your sleep. Avoid lack of sleep, and it's particularly true in certain epilepsy syndromes such as the juvenile myoclonic epilepsy, for example. Now, with that, I would like to conclude, and I hope I could convince everybody that good sleep is important, and it's particularly important for people with epilepsy. And sleep disorders and poor sleep can be managed with proper interventions. However, the talk by no means should replace a medical visit, and really if there are problems with sleep, please don't hesitate to consult with a sleep specialist, usually in addition to your epileptologist. And with that, I would like to thank you for your attention.
Thanks very much. That was really beneficial, and I think what a good talk to actually finish the evening on as well. And just to go through, there was a lot of comments, and I suppose one which stands out, which many of you will probably be very familiar with, is the impact of nocturnal seizures on the person the day after, the following days into weeks, depending on the person themselves and the impact that has. So, with that, I also wanted to talk to you about why do some people often have seizures on or soon after waking?
Mm-hmm. As I said, there is a lot of various components. The one is evidently genetic, what we heard. So certain types of epilepsy, it's really this awakening type of epilepsy where usually it is one awakes in the morning, then one goes up to the bathroom and the seizure happens. So it's a certain type of epilepsy where this is very characteristic, but then in general we know that 90% of all people with epilepsy have a circadian regulation of the seizures, and then it depends where if it in case of a focal epilepsy, where the focus is located, right? Certain types of epilepsy are very prone to have seizures during sleep, others have it during the morning, so it all depends. But yes, seizures during sleep, it's very frequent, and indeed this is really something what I always tell my colleagues, because there are still epileptologists out who would say like, oh yeah, it's good that it happens during sleep because actually this is more safe than during the day. And I would argue no, it's at least as important, because what I know from my patients with sleep-related epilepsy, they truly don't have a good sleep. And then I remember the case of one of our patients who underwent then surgery, became seizure-free, and she said, you know what, you asked me about my sleep a long time ago, and I said, yeah, it's good, I think, but now after I have no longer seizure, I only realize, how poor it was and what a pleasure is now to be able to sleep through the whole night. So it has significant impact.
Okay, brilliant. Thanks very much. And this is nearly the opposite of it. Can anti-seizure medication affect sleep, taking a person a longer time to fall asleep?
The answer is yes, it can. It depends on the type of medication. I mean, I can just say that, for example, one medication where I quite frequently notice it, albeit it's still rare, but it can be, it's lamotrigine, for example. And then what I do there, if a patient reports that, what I try to do is just to give it 1 or 2 hours before, so maybe that can be then helpful for that. Evidently, this is the thing, right? When we as physicians choose anti-seizure medication, we have a lot of different factors. Because there's many medication out, and so it's really for every patient very individualized and hard thinking, what is the best choice for this patient before me? And then evidently, if the patient has certain conditions, one can give also medication that are, for example, good for sleep. So it always depends. One always needs to look at all comorbidities, at the sleep, at the epilepsy type to find the optimal medication for everybody. Yeah.
Perfect, thank you. And another question is the pros and cons of using white noise to sleep, or rain sounds, or all the different things on YouTube. What is your opinion?
That's a good point. I mean, it's like, I know that for some people it might be soothing, and if it helps to achieve the good sleep, then why not? I mean, I personally think really the quiet and dark environment, this is what I would like. But I know I just had to laugh about the white noise, because actually we were currently reconstructing a sleep lab facility, and so basically in the US they have a lot of air conditionings, and so these air conditionings are not noise free, and so we were advised to put in some white noise to make it more in this. So that's
very good.
It depends.
Yeah, thank you. And okay, can you sleep too much? Asking for a friend.
Yeah. So, I think if you were to tell me, it's really on the weekend I sleep too much, okay, then it's very simple. The answer is that probably you sleep too less during the week, and that's why you need to catch up sleep.
Okay, weekend hibernation.
And then the next aspect is evidently with certain pathologies such as sleep apnea syndrome, what we not unfrequently see is that because these patients with the breathing stops, right, they get a very fragmented poor sleep. And that is then the reason why, to compensate for this poor quality, they sleep longer to compensate. So sometimes it can also be an indication for a pathology, but then, like always in life, it's a Gaussian distribution, and there are some people who need more sleep, some people who need less sleep, so it all depends.
Perfect. Thanks very much, Dr. Frauscher, for your input tonight.